This chapter covers integumentary or skin diseases and disorders. Contact dermatitis, as it sounds, is due usually to a contact with something that irritates the skin. So it's triggered by whatever that happens to be. Um, Poison ivy would be one of the most common types of contact dermatitis. Um, you can even get it as a matter, a lot of times whenever people find poison ivy, they want to maybe burn it away, burn it off, or maybe cut it back and burn it off, whatever. But just the smoke and that being produced into the air, pushed into the air, can actually cause people some problems. So it's one of those things you have to be really careful about even getting rid of. But contact dermatitis could be from dyes, soap, anything that comes in contact with the skin. Um, it's going to cause the skin to get irritated, um, more like an allergic response. So they may have uh, redness, swelling of the tissue, vesicles. Um, as I said, poison ivy is one of the most common, but also in our area, poison oak, poison sumac, both are also common. For some people, perfumes or suntan lotions can also be a problem. Um, for some, tetracycline may be an issue as an antibiotic. So, a lot of reasons that people may get it. Uh, if depending on the significance of the problem, they may be put on methylprednisolone or Medrol or prednisone. That may be one of the treatments. Um, Depends on how intense an episode that it happens to be. Um, the first preventative would be if you know you come in contact with something that is going to cause a reaction, then getting that off the skin quickly is, or away from the skin is quickly the first thing you want to do. Then you may also want to wash it away from the skin at times. It develops in three ways. Uh, Irritation, chemical or mechanical, contact, or can also be photoallergy as well. So, for some people, perfumes or suntan lotions can also be a problem. Um, for some, tetracycline may be an issue as an antibiotic. So, a lot of reasons that people may get it. Uh, if depending on the significance of the problem, they may be put on methylprednisolone or Medrol or prednisone. That may be one of the treatments. Um, Depends on how intense an episode that it happens to be. Um, the first preventative would be if you know you come in contact with something that is going to cause a reaction, then getting that off the skin quickly is, or away from the skin is quickly the first thing you want to do. Then you may also want to wash it away from the skin at times. It develops in three ways. Uh, Irritation, chemical or mechanical, contact, or can also be photoallergy as well. So, atopic dermatitis is more of a chronic skin inflammation, and you see it more commonly in families that have conditions of allergic reactions already. Um, Usually, you can see it on the face, the neck, elbows, knees, those kind of areas. Usually, they itch, so they'll have pruritus. Um, and it basically is a rash with vesicular or exudative eruption. So basically, vesicles or those that have broken open. In children, you see it in as a dry, leathery vesicles. In adults, you may not even call it vesicles because of its appearance. It is an idiopathic disease. We don't know why people have it, but we know we see it more in patients with that family history. and you also can also um, be as a result of sensitivity to certain foods or certain things that they may drink. In some cases, it's milk or orange juice would be more common. Uh, it can be triggered by stress or anxiety. Uh, Treatment reduce the frequency and severity of eruptions and relieving the itching. So it's one that you see um, a lot of times, and it's one that is not going to go away quickly or easily typically. Urticaria, or its more common name, hives, we see that and with symptoms such as itching. Usually the skin will get red, you'll get a swollen area, basically a little swollen lump, rash-like lumps. Um, it's not uncommon at all, and sometimes it simply comes up in a few hours, goes away. Uh, the only thing that in most cases you have to be the most concerned about is if it's a result of uh, more of an anaphylactic reaction where they start to develop respiratory symptoms. And in that case, that's going to be probably an emergency visit for that patient. Um, they can have them anywhere on the skin. Um, a lot of times it may be they'll have some here, some there, and some in on the trunk or some on the legs or whatever. Um, it can also cause some abdominal distress, abdominal colic. Um, they can get them affecting the pharyngeal mucosa. So if that's happening with the swelling and all that, then you have to be concerned about the potential for obstruction. Um, so number of things you can have, but those are some of these are the more extreme things that might be involved. Most commonly, it affects the dermis and um, is a result of hypersensitivity or allergy, in other words, uh, in the release of histamine. Um, the skin gets inflamed, dilation of the capillaries, and edema, so they start getting swollen little lesions. Uh, if it's allergy based, and of course, removing whatever that allergen is would be your primary role in treating the problem. Of course, since it creates an increase in histamine, antihistamines would be one of your treatment choices. Uh, More common things that will cause it is shellfish and strawberries, peanuts, sometimes other types of nuts, um, medications, and most commonly antibiotic there, it would be penicillin. Can be as a result of stings or bites, you know, from stings or bites from bugs. Um, Another consideration is if you have a lot of irritation of the skin, the potential for infection. Um, So a number of different issues we have with this. Treatment is most commonly going to be prednisone or methylprednisolone. Psoriasis is one of the more common skin disorders that you see. It's going to be a scaly-like surface of the skin with kind of plaque-like areas. Um, Typically, they'll look kind of dried out on the surface and may crack or look crusty looking. Um, They kind of are a thicky, flaky like area, and a lot of times there'll be a red patch underneath, um, and then it'll be covered with scaly white patches. So it's kind of a mixture of colors. Um, don't know why patients get it. Probably genetic because you do see it running in families. Um, maybe they may itch, they may get sore, that kind of thing. It's basically to an overgrowth of tissue. Most common areas that you see this in is the scalp, the outside of the arms and legs, um, especially at the elbows and knees. You see these more commonly. It is thought to probably be an autoimmune disease. One of the most easily identifiable tools with this is the white silver scaly patches. That's pretty specific for psoriasis. So sight is probably the first part of the diagnosis. The goal is treating it, reducing the inflammation, slowing down the cell growth because we said it's an overgrowth of cells or too frequently developing growth of cells. Um, and keeping the skin moist because we said it's dry uh, patches. If we keep them moist, it also keeps down some of the irritation. Treatment options, um, in some cases, they may suggest the use of ultraviolet light, and that's going to disrupt the cell production and make it slow down. There's also some medications topically that can be used. They can use steroid creams. There's also something called cold tire preparations that can be used. Um, and then some of the retinoids or the vitamin A kind of things may be used as well. Low dose antihistamines. And for just comfort category, oatmeal baths might be used. It's not a cure. Um, if, in most cases, if we can't find the cause, it's much harder to find the cure. Rosacea is a chronic inflammatory skin disorder. The skin gets red. It's on the face. The skin gets red, and it might be just on a temporary basis be confused with a flush or a blush of the skin, but it doesn't go away. So it's kind of looks somewhat like that. Um, it can also get in the eyes and cause some eye issues. Um, Usually, it comes on kind of slowly. Um, we might think they have been sunburnt, but obviously, if the sun's not been out for a few days, they shouldn't be sunburnt. Or they might say, well, it looks like they're just getting an acne. Um, the redness is the most obvious thing you're going to see. The skin gets dry. It has pus-filled pimples. The blood vessels on the face enlarge uh, and show to the skin as red lines, so they look like they have little red cracks there. Um, And then, of course, ocular rosacea, which is where it gets in the eyes, is not nearly as common. I've known a few people who've had this, and it is a chronic problem, but um, they will have uh, phases where they are better and phases where it flares up. This is another skin disorder that we don't really know what the cause is. There is a theory that says maybe this happens more often in patients who blush or flush more often. But that's only a theory at this point. It's not been proven. We do know that people who are paler skinned or lighter complected typically have this much greater extent than those who aren't. Um, we also suspect it might be inherited, and it's simply diagnosed by history and recurring episodes. It isn't infectious, it isn't contagious. Um, so most of the time, it's something they have ongoing, but it comes and goes.